video, I'll be doing the hand PA projection, hand PA oblique projection, hand lateral projection, and hand fan lateral projection. Hand PA projection. Position of part. Rest the patient's forearm on the table and place the hand with the palmar surface down on the IR. Center the IR to the MCP joints and adjust the long axis of the IR parallel with the long axis of the hand and forearm. Spread the fingers slightly. Ask the patient to relax the hand to avoid motion. Prevent involuntary movement with the use of adhesive tape or positioning sponges. A sandbag may be placed over the distal forearm. Shield gonads. The central ray of hand PA projection is perpendicular to the third MCP joint. The position of patient in hand lateral projection, mediolateral or lateromedial, extension and fan lateral are the following. Seat the patient at the end of the radiographic table with the forearm in contact with the table and the hand in the lateral position with the ulnar aspect down. Alternatively, place the radial side of the wrist against the IR. However, this position is more difficult for the patient to assume. If the elbow is elevated, support it with sandbags. The central ray of hand lateral projection, mediolateral or lateromedial, extension and fan lateral is perpendicular to the second digit MCP joint.
Hi, my name is Faith E. Kalimutan, a third-year BSRT. For this video, I will be doing the hand lateral inflection, AP oblique projection, Norgard method, and ball catcher's position. Third is the AP axial projection, the Brewerton method.
Lateral projection in hand, lateral medial inflection. Position of the patient. Sit the patient at the end of the radiographic table. Ask the patient to rest the forearm on the table and place the hand on the IR with the ulnar aspect down. Position of part. Center the IR to the MCP joints and adjust it so that its midline is parallel with the long axis of hand and forearm. With the patient relaxing the digits to maintain the natural arc of the hand, arrange the digits so that they are perfectly superimposed. Have the patient hold the thumb parallel with the IR or, if necessary, embolize the thumb with tape or sponge. The central ray perpendicular to the MCP joints, entering MCP joint of second digit. AP oblique projection, Norgard method. Position of patient. Sit the patient at the end of the radiographic table. Norgard recommended that both hands be radiographed in the half supinate position for comparison. Position of part. Have the patient place the palms of both hands together. Center the MCP joints at the medial aspect of both hands to the IR. Both hands should be in the lateral position. Place 2 45-degree radiolucent sponges against the posterior aspect of each hand. Rotate the patient's hand to a half supinate position until the dorsal surface to each hand rests against each 45-degree sponge. Extend the patient's fingers and abduct the thumb slightly to avoid superimposition over the fingers. The original method of positioning the hands is often modified. The patient is positioned similar to the method described except that the fingers are not extended. Instead, the fingers are cupped as if the patient were going to catch a ball. Comparable diagnostic information is demonstrated using either position. The central ray perpendicular to a point midway between the both hands at the level of the MCP joints for either of the two patient positions. Hand, AP axial projection, Brewerton method, position of patient, seated at the end of the table, hands supinated with fingers slightly spread and flat in IR. Flex the MCPJ so that the shaft of the MC forms 45 degrees with IR. Centrally, laterally towards the thumb, 45 entering a third CMC joint.
Good day, everyone.
Hi, my name is Jessica May F. Ihara. I will demonstrate to you the raised trapezium PA axial oblique projection, Clemens-Nakayama method, and also tangential projection modification.
Trapezium PA axial oblique projection, Clemens-Nakayama method. Position of the patient. With the patient seated at the end of the radiographic table, place the hand on the IR in lateral position. Position of part. Place the wrist in lateral position resting to the ulnar surface over the center of the IR. Place a 45-degree sponge wedge against the anterior surface and rotate the hand to come in contact with the sponge. If the patient is able to achieve ulnar deviation, adjust the IR so that the long axis of the IR and the forearm align with the central ray. If the patient is unable to comfortably achieve ulnar deviation, align the straight wrist to the IR and rotate the elbow end of the IR and arm 20 degrees away from the central ray. Shield gonads. Triple bridge tangential projection. Position of the patient. Seat or stand the patient at the side of the radiographic table to permit the required manipulation of the arm or X-ray tube. Position of part. The originators of this projection recommended that the hand lie palm upward on the IR with the hand at right angle to the forearm. When the wrist is too painful to be adjusted in the position just described, a similar image can be obtained by elevating the forearm on sandbags or other suitable support. Then with the wrist flexed in right angle position, place the IR in the vertical position. Shield gonads. Central ray. Directed to a point about 1 1/2 inches or 3.8 centimeters proximal to the wrist joint at the caudal angle of 45 degrees.
Tina, and I am going to demonstrate the first carpometacarpal joint, AP projection, Robert method, and in wrist in the scaphoid series, PA axial projection, stretcher method. First carpometacarpal joint, AP projection, Robert method. Position of the patient. Seat the patient sideways at the end of the radiographic table. The patient should be positioned low enough to place the shoulder, elbow, and the wrist on the same plane. The entire limb must be on the same plane to prevent elevation of the carpal bones and closing of the first carpometacarpal joint. Position of part. Extend the limb straight out on the radiographic table. Rotate the arm internally to place the posterior aspect of the thumb on the IR with the thumbnail down. Place the thumb in the center of the IR. Hyperextend the hand so that the soft tissue over the ulnar aspect does not obscure the first carpometacarpal joint and ensure that the thumb is not oblique. PA axial wrist for scaphoid stretcher method. Position of the patient. Seat the patient at the end of the radiographic table with the arm and axilla in contact with the table, and rest the forearm on the table. Position of part. Place one end of the IR on a support and adjust the IR so that the finger end of the IR is elevated 20 degrees. Adjust the wrist on the IR for a PA projection and center the wrist to the IR. The central ray is perpendicular to the table and directed to enter the scaphoid.
Good day, I am Sydney Margaret Ayubag, a third-year BSRT student. For today's video, I'll be demonstrating the procedures such as first carpometacarpal joint, AP projection, Burman method, and wrist in scaphoid series, PA and AP projections, Rafford-Long method.
First, carpometacarpal joint, AP projection, Burman method. Position of patient. Sit the patient at the end of the radiographic table so that the forearm can be adjusted to lie approximately parallel with the long axis of the IR. Wrist scaphoid series, PA and PA eggshell projections, Rafford-Long method. Position of patient. Sit the patient at the end of the radiographic table with the arm and forearm resting on the table. Central ray, perpendicular and with multiple cephalad angles. With the hand and wrist in the same position for each projection, 4 separate exposures are made at 0, 10, 20, and 30 degrees cephalad. The central ray should directly enter the scaphoid bone. Collimation should be close to improve image quality.
Hi, I'm Bian Marie and I will going to perform the different procedures for first to fifth digits. When radiographing individual digits except the first, take the following steps. Place the extended digit with the palmar surface down on the unmasked portion of the IR. Separate the digits slightly and center the digit under examination to the midline portion of the IR. Center the PIP joint to the IR. Extend the digit to be examined. Close the rest of the digits into a fist and hold them in complete flexion with a thumb. Immobilize the extended digit by placing a strip of adhesive tape, a tongue depressor, or other support against its palmar surface. The patient can hold the support with the opposite hand. Adjust the anterior or posterior rotation of the hand to obtain a true lateral position of the digit. Place the patient's forearm on the table with the hand pronated and the palm resting on the IR. Center the IR at the level of the PIP joint. Rotate the hand externally until the digits are separated and supported on a 45-degree foam wedge. The wedge supports the digit in a position parallel with the IR plane so that the interphalangeal joint spaces are open. Put the patient's hand in a position of extreme internal rotation and rest the thumb on the RI. Adjust the position of the hand to ensure a true AP projection of the thumb. Place the hand in the lateral position. Rest the elevated and abducted thumb on a radiographic support or hold it up with a radiolucent stick. Adjust the hand to place the dorsal surface of the digit parallel with the IR. This position magnifies the part. Place the hand in its natural arc position with the palmar surface down and fingers flexed. Adjust the arcing of the hand until a true lateral position of the thumb is obtained. With the thumb abducted, place the palmar surface of the hand in contact with the IR. Ulnar deviate the hand slightly. This relatively normal placement positions the thumb in the oblique position. Extend the limb straight out on the radiographic table. Rotate the arm internally to place the posterior aspect of the thumb on the IR with the thumbnail down. Place the thumb in the center of the IR. Ensure that the thumb is not oblique. Long and Rafford state that the patient may hold the fingers back with the other hand. Place the IR under the wrist and center the first CMC joint to the center of the IR. Hyperextend the hand and have the patient hold the position with the opposite hand or with a bandage loop around the digit.
Tightly wrap a rubber band around the distal portion of both thumbs and place a roll of medial tape between the bodies of the first metacarpals. Ensure the thumbs remain in PA plane by keeping the thumb nails parallel to the cassette.
Hi, good day. I'm Erica Tisalgoro, a third year BSRT, and for this video, I'll be doing the carpal bones, carpal bridge, tangential projection, carpal canal, tangential projection, inferior-superior projection, Gyno-Hart method, and tangential projection, superior-inferior projection, Marshall method.
Tangential projection. Position of patient. Sit or stand the patient at the side of the radiographic table to permit the required manipulation of the arm or X-ray tube. Position of part. Hyperextend the wrist and center the IR to the joint at the level of the radial styloid process. For support, place a radiolucent pad approximately 3/4 inch thick under the lower forearm. Adjust the position of the hand to make its long axis as vertical as possible. To prevent superimposition of the shadows of the hamate and pisiform bones, rotate the hand slightly toward the radial slide. Have the patient grab the digits with the opposite hand or use a suitable device to hold the wrist in the extended position. Position of part. When dorsiflexion of the wrist is limited, Marshall suggested placing a 45-degree angle sponge under the palmar surface of the hand. This slightly elevates the wrist to the place the carpal canal tangent to the central ray. A slight degree of magnification exists because of the increased object to image receptor distance. Central ray. Directed to the palm of the hand at the point approximately 1 inch or 2.5 cm distal to the base of the third metacarpal and at an angle of 25 to 30 degrees to the long axis of the hand.
Hi, this is Asharta Jasa, a third year BSRT student. For this video, I'll be demonstrating the wrist PA projection, the lateral projection, which is the lateral medial, the PA projection, which is the ulnar and the radial flexion. PA projection, position of patient. Sit the patient low enough to place the axilla in contact with the table or elevate the limb to shoulder level on a suitable support. This position places the shoulder, elbow, and wrist joints in the same plane to permit right angle rotation of the ulna and radius for the lateral position. Central ray is perpendicular to the mid-carpal area. Lateral projection, lateral medial. Position of patient. Sit the patient at the end of the radiographic table. Have the patient rest the arm and forearm on the table to ensure that the wrist is in lateral position. Position of part. Have the patient flex the elbow 90 degrees to rotate the ulna to the lateral position. Center the IR to the carpal and adjust the forearm and hand so that the wrist is in true lateral position. Central ray is perpendicular to the wrist joint. PA projection under ulnar flexion. Position of patient. Sit the patient at the end of the radiographic table with the arm and forearm resting on the table. Position of part. Position the wrist on the IR for a PA projection with one hand cup over the joint to hold it in position. Move the elbow away from the patient's body and then turn the hand outward until the wrist is in extreme ulnar elevation. Central ray is perpendicular to the scaphoid.
The central ray angulation of 10 to 15 degrees proximity or distance.
PA projection under radial flexion. Position of patient. Sit the patient at the end of the radiographic table. Position of part. Position the wrist on the IR for a PA projection. cup one hand over the wrist joints to hold it in a position. Then move the elbow toward the patient's body and turn the hand medially until the wrist is extreme radial deviation.
Good day everyone, my name is Shaiva Lady Torino, a third-year BSRT student, and today I will be doing the procedures for the wrist. The first one will be the AP projection. The second will be the PA oblique projection, lateral projection, and the third one will be the AP oblique projection, medial rotation.
Wrist, AP projection, position of patient. Sit the patient at the end of the radiographic table. Position of part. Have the patient rest the forearm on the table, with the arm and hand supinated. Place the IR under the wrist and center it to the carpals. Elevate the digits on a suitable support to place the wrist in close contact with the IR. Have the patient lean laterally to prevent rotation of the wrist. Central ray, perpendicular to the mid-carpal area. PA oblique projection, lateral rotation, position of patient. Sit the patient at the end of the radiographic table, placing the axilla in contact with the table. Position of part. Rest the palmar surface of the wrist on the IR. Adjust the IR so that its center point is under the scaphoid when the wrist is rotated from the pronated position. From the pronated position, rotate the wrist laterally until it forms an angle of approximately 45 degrees with the plane of the IR. For the exact positioning and to ensure duplication in follow-up examinations, place a 45-degree foam wedge under the elevated side of the wrist. Extend the wrist slightly, and if the digits do not touch the table, support them in the place. When the scaphoid is under examination, adjust the wrist in ulnar deviation. Place a oblique projection, medial rotation, position of patient. Sit the patient at the end of the radiographic table. Have the patient rest the forearm on the table in a supine position. Position of part. Place the IR under the wrist and center it at the dorsal surface of the wrist. Rotate the wrist medially until it forms a semi-supinated position of approximately 45 degrees to the IR. Central ray, perpendicular to the mid-carpal area. It enters the anterior surface of the wrist midway between its medial and lateral borders.